So welcome to the Seeing is Believing Southeast Asia and Western Pacific Regions webinar. My name is Susan Evans and I'm the Seeing is Believing Project Officer for IAPB. So the theme for this Seeing is Believing webinar is Financing Eye Health, and we have some fantastic presentations for you today. Thank you all for attending. I really appreciate you taking the time to join us and be part of our learning community. We've actually got 37 people registered today from over 10 countries in the region, which is fantastic. If you would like to introduce yourself to the group today, you can write your name and which country you are from, organisation, in the chat box in your side panel of GoTo. So I'd like to give a big thank you to our webinar presenters today. We've got Debbie Muirhead, the Senior Economist, the Fred Hollows Foundation, Lexi Wang, the Program Manager, Orbis China, Ming, Program Manager, the Fred Hollows Foundation China, and Sally Crook, Seeing is Believing Program Manager, IAPB. So the agenda for the webinar will be welcome and housekeeping notices from me. Then there'll be an introduction to the opportunities and challenges of financing eye health in the Southeast Asia and Western Pacific regions by Debbie. A presentation on financing eye health in the Orbis China Seeing is Believing project by Lexi Wang. Presentation on financing eye health in the Fred Hollows Foundation China Seeing is Believing project, Ming. And then after the presentations, I will chair a question and answer session. And finally, Sally Crook will make some concluding remarks. So we aim for the webinar to be around 1 hour. So firstly, some housekeeping points. So I've shared my screen and you should be able to see the screens of the fellow presenters during the little sort of the go-to window. And you can see under the handout section, you've got PowerPoint presentations and project overviews and the agenda. And we aim for this session to be participatory. So as attendees, you will have the chance to ask questions by typing them in the chat box. There will be sort of during the question and answer session at the end. So if you have any questions for presenters, please do type them in the chat box. And the chat box can be found again on that right-hand panel of your GoTo. And you can either post questions during or after the presentations. It's a good idea to close down all other web applications, for example, Google, Outlook, Skype, as this will give you a better quality of call. And if you have headphones, please use those as it will make the sound a bit better. Now, I am recording this webinar and it will be uploaded onto the IAPB website, and I'll send around the link in a few days. Finally, at the end of this webinar, I will be sending you a survey for your feedback. So the theme of this Seeing is Believing webinar is financing eye health, and the presenters today will share how their Seeing is Believing projects are engaging with different eye health financing models, and we hope that listeners will be able to identify how you can engage with eye health financing models in your own locations. So I'm now pleased to introduce Debbie Muirhead, the Senior Economist, the Fred Hollows Foundation, to give an introduction to some of the challenges and opportunities of financing eye health in the Southeast Asia and Western Pacific regions. So Debbie, over to you.
Thanks very much, Susan. And am I clear, Susan, just to check?
Yes, loud and clear.
Great, thank you. Thanks everyone for joining the webinar. As Susan said, I'm a health economist by background for a long time, for 25 years, but only in eye health for the last 2.5. So definitely not an eye health expert like many of you are, but really worked on health financing and health economics for a long time. So that's my background. Just to introduce, so why should the eye health sector, why should you as eye health program managers be interested in health financing? What is all this health financing discussion that's growing all about? And I've really got three key reasons. One of them, because a lot of the stakeholders, particularly national governments, international bodies that we work with, have a keen focus on health financing. And where in a lot of contexts, I know that you all face challenges that sometimes eye health can be lower on the priority list of many of these policymakers than we might like. Health financing and universal health coverage in particular is high on their priority list at the moment. So if we can link those two and show them how eye health actually impacts and is a good tracer for looking at universal health coverage and health financing issues, it gives us an extra inroad to useful policy dialogue and practice dialogue with senior stakeholders. Another reason is I hope for all of us that are working as donors or NGOs in the eye health space, that sustainability in eye health service delivery. And I'm not just talking about financial sustainability, but sustainability in the WHO definition of financing and delivering services in a way that does not risk interruption. Then that should be a primary concern of ours as well, and where we often deliver eye health services quite separately and what's called vertically, then looking at how that fits into a broader health financing system and how we can both leverage and complement that financing system helps us think about the sustainability of what we do. Also, because we know that particularly in our region in Southeast Asia and Pacific, the WIPRO region, populations are aging rapidly. And so the needs for financing for eye health care are growing. So we should care about that as well. But I think one of the most interesting things in health financing is that for eye health is that it's a really useful lever to improve equity, quality in eye care and coverage of eye care services. So health financing isn't in itself an end, but it's a means to an end to improve those things. And particularly how we talk about how healthcare is purchased, how people that pay for the healthcare, whether it be a government, whether it be a person, how they pay for it is called purchasing, and that can hugely influence that coverage, quality, equity, efficiency with which we deliver eye health services. So that's another big reason. In our region, in the Western Pacific region, and particularly in Southeast Asia, as many of you will know and be more familiar with, in each of your countries, national health insurance is now becoming a big issue and has been there for some time. PhilHealth in the Philippines, Vietnam Social Security in Vietnam, NCMS and URBMI, etc. in China. That national health insurance as a vehicle towards universal health coverage is really important. And as many of you probably know, eye health and particularly cataract surgery has been between the second and fifth highest total claim to a lot of that health insurances. So it's almost becoming a target of some governments and health insurers now to say, hang on, this is costing us too much. What do we do about this? So it's really important in our context to look at how we're increasing efficiency, how we're making sure that people that really need the services the most are getting them, that they're of quality, and health financing can really impact that, particularly in our region of national health insurance. Universal health coverage obviously is a huge priority globally now, one of the highest. And so that considers two things: the coverage of services of sufficient quality to be effective for those who need them. And then secondly, that's the first part, so coverage, and secondly, financial protection, that people should be able to access those, in our case, eye health services, without facing financial hardship. And both of those things relate directly to health financing. For the financial protection one, we know that if out-of-pocket costs, if out-of-pocket healthcare payments in a system are more than 30% of total revenue going into the healthcare system, then the risk that our population are falling into poverty by paying for healthcare increases dramatically. And where that gets over 40%, then that increases even more. And countries like China and Vietnam and Cambodia are in some of the highest categories of healthcare cost-related poverty and people falling into poverty from paying for healthcare. And in fact, our region is the region where that risk has grown the most over the last 10 years. So when we're delivering eye care services, hopefully we're not only interested in the coverage of those services, but how much are we risking people who access those services falling into poverty from doing that? Or how much does the cost or potential cost of those services dissuade people from and place a barrier to people using those services. So they're all reasons why health financing is so important in our region. And I hope I haven't taken more than my 5 minutes.
Perfect, Debbie. Thank you so much for that. I mean, I've actually had the pleasure of listening to a couple of presentations from Debbie before at various comms, and I think looking for the eye health sector to have a look at eye health financing and look at, you know, through that lens is really interesting and really useful for all of us. And I always learn something from when I hear Debbie talk. So thank you so much, Debbie, for that.
Thanks, Susan.
Okay, great. So hopefully that's given a bit of an overview of the issue and the situation. So now let's hear from our Seeing is Believing project. So for our first sort of PowerPoint presentation, let me introduce Lexi Wang, the program manager for Orbis China. And Lexi, I'm going to make you the presenter now. Right, so we will be able to see your screen and you'll be able to click us through your presentation. Let me just unmute you. Yeah, okay, so Lexi, over to you.
Yeah, thank you, Susan. Can you hear me?
Thanks.
And the screen is okay?
Yeah, screen's perfect
okay.
and I can hear you.
Okay.
Lovely.
Thank you. Hello, everyone. And my topic for today's webinar is to strengthen country hospital sustainability through training project. And, oh, sorry. The first of all, I want to talk about something about blindness data in China now. There are about 6 to 7 million blind people in China, and 70% of blind people live in a rural area of China, and 50% blindness are caused by cataract. And in terms of eye care service capacity, when we talk about the 70% eye care service in urban area, this service capacity includes human resource equipment as well. And from 2013, the Chinese government started healthcare system reform, and the medical insurance scheme has covered 95% of the population all over the country since then. And in terms of cataract surgery, 2 to 3,000 renminbi equals to 3 or 500 US dollar can be reimbursed by medical insurance for each cataract surgery. And when we talk about financing eye health, a most common fundraising way for a public county hospital in China includes, as I list, the first one is government investment, such as a land, a building, and part of equipment. The second one will be government medical insurance, because the insurance will pay the hospital based on the service volume and reimbursement for different diseases. And the third one is income. This is a profit from business operation and the service provided by the hospital. And the last one is maybe donation. It may come from blindness prevention projects, just like SiB project, like NGO and Disabled Persian Federation, etc. And the major service delivered in county hospitals still in China still be the cataract and refraction, the primary eye care service. And to know the running cost of the hospital, we need to know some economic concept firstly. but I'm not the expert like Debbie, so I just copy some concept from my over financial director presentation. So the first one is a sunk cost and opportunity cost. The sunk cost is the original investment before the I department is set up. When the I department is established, the original investment cannot be withdrawn. If the business running failed, no return for the investment, right? The opportunity for other investment will also be lost. The second one is fixed cost and variable cost. The cost for facilities, equipment, electricity, water, human resource, and management is all fixed cost. It's about 80–90% for total cost. And the variable cost is include consumables, supplies. It's about 10 or 20 total cost. The third concept is scale economics. Here I can make example. If a county hospital monthly fixed cost is $60,000 and the actual consumable cost for each cataract surgery is 100, if 30 surgeries a month conducted, the unit cost would be, after calculate, is $2,100. But if 300 surgeries a month conduct, the unit cost would be $300. And it's a big difference. And I have mentioned before, the medical insurance can reimburse the cataract surgery in China. If medical insurance pay $500 for each surgery, then in the first scenario, the hospital will have 48,000 deficit. While in the second scenario, the hospital will have 60,000 profit. So I didn't count the extra money that may come from patient, just from insurance. So it's a big difference. So we know total cost for cataract surgery would be include direct cost, allocated cost, and depreciation cost. So based on the above example, we can get this curve. We know the unit cost of each surgery will change with surgery amount. The more surgeries operated, the less unit cost. So this slide is a mathematics model. Our finance director helped us to make it to do break-even point and quantity analysis. The data came from a county hospital we trained before, based on given price of cataract surgery, consumables, and screening cost. We can get the break-even point surgery volume. Here equals to 1,086. After this point, we can see the benefit is more than cost. The more surgery we done, the more profit the hospital can get. And the profit is highly increased after break-even point. There are three variables can be changed. Here I marked in yellow: consumables, other cost, and surgery price. If the variables value change, the point will shift left or right. When the variable cost decreased and the surgery volume we need to make even would be decreased as well. From this formula, we can get a conclusion that decreased variable cost and increased surgery volume are the important ways for a county hospital to raise more money. Please note the given price here is 3,000 renminbi, and I mentioned in the first slide, the medical insurance can reimburse 2,000 or 3,000 renminbi for each cataract surgery in China. So therefore, it's not possible for county hospital to do free or low cost surgery to reach break-even point in China. So based on above analysis, we suggested a sustainable cataract service model in county hospital. It's called low cost, high volume, and high quality service model. When the surgery is low cost, patients can have free charge or discount surgery. It will bring more patients to hospital, make the high volume possible. And high quality and good reputation of the service also have positive influence to high volume. The high out volume and the low cost help the county hospital to get more income. The final result we can get is a higher CSR, less blind people in area, and the county hospital achieve service and finance sustainable. In our project, we try to educate the county hospitals to set up this kind of a service model. We want them to know the high volume is fundamental for everything, such as hands-on training, high quality, and cost control, and earn more profit, etc. And 7 elements for all actions can contribute to achieve high volume, which includes good surgical outcome, to do eye health promotion, conduct screening, and to do low free charge surgery. And most of these elements are involved in our training project. I believe you all have already got project introduction. Here I won't talk details for the project. And as the same, there are also some elements help to achieve a high quality service, including set up efficient service to standard quality surgical hands-on training and provide good infrastructure. And our project is directly acting on this angle through hands-on training to increase service quality in the county hospital. The good reputation of the service will bring more patients coming. Until now, in our project, 125 eye doctors, 75 nurses, and 47 refractionists were trained in our project since 2016. And most county hospitals have improvement in eye care service, from patient volume, surgery volume, and also surgical outcome. Here are some pictures taken during our project implementation. You can see these are the trainees to do wet lab training in a tertiary training center, and these are trainees to do hands-on training in county hospital. And this screening, the county hospital work with the community health worker to do the screening in school and in community. And in this project, we are trying to establish an applicable training model for the county hospital in China to make county hospitals sustainable through effective training. Because through training, the county hospital can provide high quality service to increase patient volume. And through training, the service scope expanded. The county hospital can provide service they cannot before, also help them to increase income. And through cooperation with high-level tertiary hospital to deliver training to advocate government increasing investment in medical insurance, which like the county hospital can conduct more and more low and free charge surgeries. And project also did program management training to the administrative staff, which make the county hospital have a chance to get more extra money, more projects possible. So finally, that's our final goal, to make the county hospital can achieve service and finance sustainability. So that's all for my presentation. Thank you.
Thank you, Lexi. That's really interesting and great to have the perspective of the county hospital. And, you know, it really shows how important it is looking at that level of detail around the, you know, the financial numbers in terms of using that for, you know, advocacy. So, yeah, really interesting. Thank you so much. Right. Okay. So, yeah, thanks. So just as a reminder to our listeners, if you have any questions for the presenters, please do type them in the chat box and I will ask them at the end of all of our presentations. And then thirdly, let me introduce Ming, the Program Manager for the Fred Hollows Foundation China. And Ming, I'm just going to make you the presenter so we'll be able to see your slide. And let me just check You're unmuted. Okay.
Hi.
Hi,
Can
Ming.
you see my screen?
Yeah, we can see your screen and hear you loud and clear. So, Ming, over to you.
Okay, thank you. Hello, everyone. Many thanks for offering this opportunity to me to sharing our key findings from the health financing research, financial barriers and hardship from accessing services from Cataract in Yunnan province. My presentation including 5 main contents. The first, I would like to introduce some background and local context regarding on the health insurance system in China. Originally, it is a high centralized system. The central government will make the national policy and oversee the implementation. The city level and county level will localize the policy. And in China, we have multi-medical security system. The major one is the social health insurance, which is provided by the government. We also have commercial medical insurance as a supplementary and charity aid. We have high coverage of health insurance in China. Take Yunnan province as an example. The coverage of health insurance is more than 98% in 2017 from this research. And also different rates of premium and the reimbursement for different types of health insurance. And the reimbursement also differ across level of health facilities and a lower reimbursement ratio for higher level of care. In 2017, Chinese government merged urban and rural residents health insurance scheme, and this will make rural population have better access for health facilities. And most eye surgeries are included in health insurance, but the outpatient costs only can reimburse in township clinics and village clinics, and there is a gap. There is a cap. Also, we have different policy for reimbursement. For example, such as a major contribution of the cost of cataract surgery IL, the reimbursement percentage will be reduced by level of care. There are in our study, there are 3 phases in this research, which is from June 2017 to December 23. And also, my presentation is only focused on the first 2 phases. In this research, we covered 4 counties in 2 prefectures of Yunnan province. The total population is around 2.59 million people. And the purpose of this study is to understand, quantify out pocket cost, barrier, and burdens in taking up cataract surgery, and also to draw out the implementation for increasing financial access and protecting already poor population from further risk of financial hardship from the cataract surgery. And we focus on the health financing, particularly insurance and arrangement. In our this research, we have 2 phases. In the first phase, we have 2 approach or methodology. The first one is the desk review, and second is a focus group. Since the county level hospital is the main service providers in this project, so you can see the table on the left is more than 6% of respondents from the county level among all the respondents. And also we analyze of health financing policy changes from 2013 to 2017, review existing policy and its implementation and the provincial, prefecture, and county level with a focus on cataract surgery. And for the focus group interview, we also with a range of officials from health insurance office of provincial, prefecture, county health bureau. And also we interview the manager of health insurance office in the pilot hospital and health professionals from the study hospital eye department. This including general health insurance arrangement as well as cost and financing specific to cataract surgery. And in the phase 2, purpose of design interview questionnaire was developed to give a rapid but useful information regarding access, particularly financial to cataract surgery and estimated out-of-pocket cost from surgery were obtained, and the burden this placed on household in these two prefectures in Yunnan. And there are two sample frames. Half of respondents are people who got eye screen and diagnosis with cataract, but no have cataract surgery, and the rest half is other patient undertaking cataract surgery. The total sample size is 212. Next, I would share some key findings from our phase 1 research. In general, the proportion of contribution for health insurance paid by the patient versus government subsidy is increasing over time in Yunnan, and also the level of required co-insurance also increased over time, both placing additional financial pressures on household. And also there are some key issues in health financing with implication for eye health we found. The first one we want to share is the low reimbursement percentage at higher level of care. In the research in 2016, average cost reimbursed as a proportion of total in Yunnan was around 65%. For a county hospital and 43% for the provincial hospital. You can see the big difference between these two levels of hospital. And also the second finding we want to share is inclusion of the most outpatient services from coverage. In the national guidance is in local village and township to cover around 50% outpatient costs for rural patients. But actually, the reimbursement rate may also vary a lot. But in the county level and above, there is no reimbursement for outpatient. Costs are effectively being incurred by the patient in raising out-of-pocket costs and lowering the financial protection. And the third is the cost and the reimbursement of intraocular lenses. The policy is quite various from county to county. A domestic IOL ranging from US 28 to 49 will be fully reimbursed. But for the imported IOL over US 140, it only can reimburse US almost 100, and the patient pays the remainder out of pocket. However, the IOL charges range from US 2022 to US 1,400, which increase a high out-of-pocket payment burden. And the last thing I would like to share is a change to the inpatient days. From research, we found nearly half cataract surgery patients stay for 3 days or more, and 20 of them stay for 5 days or more. This will increase the out-of-pocket cost and also increase the cost or burden for China health system. And the next is I would like to share the key findings from the phase 2. From this phase 2 in Yunnan, the median out-of-pocket cost was just under US 300, and this is nearly the total charges or reimbursement in other countries, and also it's equivalent of up to 10% urban residents and up to 25% of rural resident annual income in counties, so which is quite high. And the higher level hospital, the higher out-of-pocket cost. Although the higher cost in higher level hospital, there is also higher percentage deductible, but there is a higher inpatient days with limited on reimbursement. And also over 80% of the poorest quartile in sample found the out-of-pocket cost difficulty or very difficult to pay versus just over 20% of the wealthiest. And nearly half of the poorest quartile in sample borrowed money or sold access to pay for cataract surgery out of pocket cost versus around 1/5 in the wealthiest. This is an important indicator frequently used in examining out-of-pocket healthcare cost burden, as it can lead to even further impoverishment of household over a long period for loss of resilience. through selling of asset or further debt burden incurred. And also we found some costs related to other determinants of cataract surgery. The top 3 barriers to surgery uptake is the first one is unnecessary, and second is the fear of surgery, and third is the cost with 90% of our respondents. And also we saw this also due to people being used to high costs associated with care, or the cost is not well known in advance. Over a third of those needing but not have surgery did not know what cost to expect, and other half expect a cost up to 60% less than actual out-of-patient pocket thing. In the phase 3, we will conduct the household service to give more robust triangulation of the result. From those findings, we have some discussions. Existing house financial arrangement under the newly merged NCMS and urban and URBMI iHealth service represent potentially large out-of-pocket costs to patients and therefore financial hardship risk, particularly to poor rural population of China. And also we found the general regulation of IOL charges along with the standardized information about cataract surgery and IOLs given to patients across the province may have increased financial risk protection. And it's also for the next is for potential coverage, the cost efficiency and the financial access. Coverage of the patient cost for selected services and the procedure could be considered, such as outpatient based on day surgery. And also when we do this research, we have some limitations due to the small sample by the hospital and overall out-of-pocket recall only, which may can cause underestimate, and telephonic view approach not varied, so we will address those in our phase 3. And also go through when we do this research, we have challenges and the lessons learned. It's very difficult to us to access health insurance related data from government departments. So the project involved key information from the Health Commission from the beginning of this research. And another challenge was to draw attention from government at the national level on health financial arrangement and financial protection. To address that, the project received experts from Beijing University who have evolved this study and linked the research and the result with the national medical reform initiatives at the national level. Finally, there is an important lesson that's learned from our field visit is to have a long, we found a proper pilot test and the data validation stop point is very essential. I think that is all my presentation today. Thank you.
Brilliant. Thank you, Ming. That's really interesting presentation, and I think really complements the Lexi's presentation, and that you're really looking at the the impact on the people who are kind of accessing surgery and some of the issues that they have to face with. So thank you so much for that. And also, I think great that you've based it on the research as well, and that it's that kind of learning from that research that's really interesting. So thank you for that. So there are presentations. I'm just going to make myself back the to show my screen. Right, so now we've had all of those excellent presentations, and I really felt like I learned something from all of them. So thank you for sharing being sort of open to sharing your learning with the SiB community. Do really appreciate that. So now we're going to have the question and answer session. So attendees, this is such a great opportunity for you to be able to ask questions to our presenters. So if you have any questions, please do put them in just type them in the chat section. and I'll group them and I'll sort of ask our presenters as they kind of come in. I've got a couple of questions myself just to kind of kick off really, but I'll just check with my other organisers just to see if any of you have got a question for any of our presenters. I'll sort of give you the opportunity first, and then if not, then I'll start asking my questions, and then once sort of questions do sort of pop in your head, please do sort of pop them in the chat section. So organisers, do you have any questions for any of the presentations that you've heard? Debbie?
I do, just a quick one, but maybe Lexi, thanks very much. Maybe Lexi and I can follow up as well separately. Really interesting presentation, Lexi, thanks. I'm just interested because globally there's been a number of cost of cataract surgeries done, and the provider costs for an adult cataract surgery usually range between about 25 and $125 US, and for a child surgery between about 90 and 300 US dollars. And with the fixed costs usually being about 1/3, with the variable costs being 2/3, but that often it gets driven by the IOL, depending on the IOL used. I'm just wondering what step-down method was used to allocate the fixed costs down to an individual cataract surgery in your work, because to me that just seemed that fixed cost seemed very high overall and very high as a proportion of total, and I'm just wondering how the fixed costs were allocated down to across departments in the hospital, within the department and unit, and then to an individual cataract surgery, that 3-step down approach.
Thank you, Debbie. Lexi, would you like to respond to that? I think you're on mute actually, Lexi.
Oh, okay.
Oh, yeah.
Can you hear
Perfect.
me?
Yeah,
Okay.
I can hear you now.
Thank you, Debbie, for your question. I'm not very sure about this, how to analyze and how to count the fixed and the variable cost. But in my opinion, because I'm not a finance people, and as I heard from our team, when we work with the different county hospitals, we if we do the free surgeries and we think after calculate, we think the cost for cataract surgery, the cost is about $1,500 US. It's about how much? Sorry. Yeah, it's about $200 US for the variable cost, like consumables, IOL, and other supplies. But for the fixed cost from the county hospital, like how to allocate it to the surgery unit surgery, I'm not sure I can answer that question.
Okay, thanks, Lexi. I appreciate the answer. Anyway, I would just, yeah, it'll be interesting to see, because that's way out of the range of any other costing study of cataract surgery.
Yeah.
So it'll be really interesting to see.
Thank you.
No, I think it's quite interesting. Susan here again. It is something that I think we're sort of all getting our head around, the health financing aspect and some of the sort of how we kind of calculate the costs and everything. Like even, for me, although it's something that comes up in Seeing is Believing projects, I think having, looking at it through that lens of, getting a health financing specialist is really helpful. And it's really helpful for us to kind of, question those kind of costs that we put down and sort of really reflect on that and think, okay, what could it be? So, thank you, Debbie. That's a really interesting kind of like way of us like looking at it. And thank you, Lexi, as well, for sort of being really open about how we're sort of looking at those costs. So, so for our listeners, if you do have any questions, just a reminder, just ask it in the chat box and just type it in. And even if it's if there's a particular issue that you're struggling with in your project or area around health financing, or how, even if it's to share your example of how you're actually managing with the health financing issue for you, then please do share. Any other of our organisers, did you have any questions? Or if not, I'll crack on with my questions for the presenters. I just thought, let me just give you the opportunity. I will ask my, oh no, sorry, Sally, please go ahead.
Okay, I just have a sort of a seeing is believing question to both of our presenters, because I know that certainly when these projects started, which was a while ago now, we didn't talk about health financing. The language that we would be talking about would be saying, future sustainability, including financial sustainability of your projects. So I'd be very interested to know, how you feel about being drawn into what is, as Debbie's alluded to, is really more serious health financing, and how comfortable you feel being in this new space, which is really getting out of just talking about project sustainability or program sustainability and into real nitty-gritty health financing issues, and how the projects have risen to the challenge. Because I think from both your presentations it's clear that both projects have really risen to what is quite a new area for eye care projects, eye service delivery projects. So I'd be quite interested, both from the Orbis perspective but also from the Fred Hollows perspective, how you've seen this work, and whether you have embraced it or it's all been a bit scary, or what's been going on in your mind as this issue has raised its head. That's my question to both the presenters. Thank you.
Thank you, Sally. That's a great question. So take turns. So Ming, we'll start off with you, and then we'll go back to Lexi to ask her questions, the same questions. So Ming, over to you. How have you found it?
Thank you. Yeah, thank you, Sally, for your questions. I think for Fred Hollows Foundation China program, we are more and more focused on health financing, not only for this seeing is believing phase 5 project, but usually when we design our project, we also consider as you mentioned, the project's perspective, sustainability. For example, we provide trainings, and also we help them to increase their patient volume, and also we set up the vision center. We want the profit from the vision center can continually to support the screening equipment procurement, and also the human resources training for our projects hospitals. And also when we do this health financing research, we also find there is a big gap between in the health insurance system in China. Usually they say China we have very good health insurance system, but actually we take into some details and also from different perspectives to examine those situations. We also found very big challenges. For example, as we mentioned, the OPD, auto patient reimbursement in the health insurance is not including the county level, but the major service uptake, especially for the cataract surgery in the in-county hospital. So we think it's a big gap. I think when we finish the phase 3 of this research, we will do the national policy brief, and we think we can continually to lobby to the government if we can increase the health protection for the people in the rural area. Yeah.
Thank you, Ming. And Lexi, the same question to you.
Thank you. About the question from Sally, I'm thinking it's quite important for me to understand how important we need to pay more attention to about this topic for health financing. because as a member of a program team, we most of our daily work is about to do project implementation and to cooperate with our partner to make the activity progress quickly and as a target. So, but when we're thinking, when I working with my director, Peter, and we discuss how to make this presentation on this topic, because I think I'm a program manager. I'm not very familiar with financing topic. So, but he gave me an open mind. He want to help us to connect the project from the training point of view to the finance. In fact, the county hospital for a county hospital, they are more interested on how to make more profit, right? At the beginning, when we design this project, when we talk about this project with our partner, they are not very interested because we don't have a lot of investment as our previous project. We give them a lot of investment on the equipment because this project is just pure training. They are not very interested. But we think the service model, the suggested service model we are talking about is help them after doing this project, we can help them to establish the sustainable training, sustainable service model. Also can help them to make a financial profit. And but the most challenge in this project is how we select the county hospital to join our project, because we found not all the county hospital can buy in our ideas. We need to select the county hospital can understand the model suggested, and they can believe after they set up this kind of a service model, they can also get increase in their financial field. So actually, we have 2 county hospital quit in the middle of the projects. They the reason is the leadership of the hospital and the director of the eye department. They don't want like their young doctors to be trained. They are not interested to make their eye department to development to develop. So this is a big challenge for us for us in doing the implementation. So after we discussed this challenge with our training center, tertiary training center. From the second year, all the training center select the county hospital really want to make their eye department develop, so they can buy in the ideas to set up this low cost, high volume service model. They can have a good result. Yeah.
Thank you, Lexi. Yeah, it makes such a difference, doesn't it? Getting a partner on board who's really keen and wants to sort of make that change. So, no, that's really, thank you both for those kind of insights. Sally, does that answer your question?
No, great, thank you. I think very, very good answers actually into the issues that are coming up in a rapidly changing financing situation in China. Every time I go there, things have moved, changed. I mean, as Ming's presentation showed, you know, merging of different insurance schemes and everything. It's a very dynamic system in China at the moment. So I think you all have to be on your toes there to understand what's driving a lot of people's thoughts and behaviours. Yes.
Yeah, absolutely. Thank you, Sally, for that. Right, now we've got some questions coming through from our listeners now. So thank you very much for that, and please do sort of keep asking your questions. So the question, we've got a couple around out of pocket payments. So I'm just going to group the two together, and then I'll ask them to our presenters. So the out-of-pocket, the first one is from Harish Kumar from Operation Eyesight. So the out-of-pocket expenditure pointed out in the study was high, but the barriers study indicated that only 9% of people thought it as a barrier. Is there a specific reason or other variable? So just be thinking about that one. And then the second one is from Ian Jones from Sightsavers. So the Yunnan example showed 80% of the poorest quartile found out-of-pocket payments difficult. Is there any evidence from other areas in China on the difficulty of out-of-pocket payments for the poorest? Are there efforts to tackle this beyond regulation of IOL charges? So again, Ming, should we start with you and then go on to Lexi, and then Debbie also sort of jump in if you want to add anything?
Sure. I think for the first questions, even only 9% respondents said cost is the main reason they don't take up surgeries. I think it's the one reason is maybe because people being used to high costs associated with healthcare in China, or because cost is not well known upfront, and also over a third of those needing but not have cataract surgery did not know what cost to expect, and another half expected a cost up to 6% less than actual out-of-pocket payment thing. So I think this may be the reason why the out-of-pocket burden is high, but only 9% people said the cost is the main reason they don't take cataract surgeries. I think for the second questions, if we have any evidence or some cases happening in other province, we don't have much more consolidated or concrete evidence. But in our other province project, we also can find some patients like they can't afford the out-of-pocket. I can give you an example. Last week, we went to Anhui province. We go to Lixing County, and we found one patient. This patient already got money, and he already go to the hospital, but he found the money is not enough to pay the hospital to get the surgery. So he go back to his hometown, and he never go to hospital again. So I think it's another example to see it's also happening in other areas in not in Yunnan but also in other poor areas in China. Yeah.
Susan, can I just add something to that?
Please, yeah, go ahead.
Just on the first question, it's probably useful to clarify that 9% was people that had been diagnosed as needing cataract. That was 9% of the group that needed cataract surgery but had not taken it up. So they hadn't actually experienced the out-of-pocket costs at that point. And when we sort of asked a question about their expectation of cost, as Ming presented in the presentation, in general, their expectation of what the cost would be was much lower than actually what the average out-of-pocket cost was. So it could be one of the reasons is that in fact they hadn't experienced the cost, there was no information about what the level of cost might be. So I'd contrast that with the finding that the poorer quartile, a number of them, a much higher percentage, said that they found the cost difficult or very difficult to actually meet.
Yeah, interesting. Thank you, Debbie. Lexi, I mean, these questions were more really on the research, but I just wanted to just throw it open to you to see if you wanted to add anything around your kind of experiences in the project on this.
Yeah, it's because it's quite new research and only in Yunnan province. We haven't project in Yunnan currently. We only have a project in my project is in Shandong, Hebei, Sichuan, Guangzhou province, the 4 provinces. But talking about in terms of IOL, I know most if the patient, the poor patient, they can use the cheaper IOL. Is all can be covered by the insurance. But if but I know most of the hospital, including county hospital, also want to get more profit from surgery. So they will introduce they will persuade some of them will persuade patients to use the high-level IOLs, is more expensive, and most of this kind of expensive IOL cannot be reimbursed by the insurance. So patients need to use their out-of-pocket money. So I'm not sure the percentage of the patients need to pay for the other kind of the IOL in different provinces.
But it's looking like it's quite a complex picture. No, thank you for that. Okay, so this is your last chance to type in any questions. I've got another question that's come in, which I'm going to ask now, but if you have any questions, then it's your last chance to ask them. I'll ask these 2 questions that have just come in, and then any other questions, and then I think we'll wrap up because we're sort of just a bit over an hour, but I think let's, you know, sort of crack on really. So this is another question from Ian Jones from Sightsavers. So it's around Debbie mentioning that the cataract tends to be quite costly for the national health insurance schemes, and so governments are thinking carefully about how it's covered. And there are some examples of governments withdrawing cataract from insurance due to costs. So have there been any debates in China in terms of including cataracts in insurance? Does anyone want to kind of jump in on that one? Ming, Lexi, Debbie, any of you want to sort of, do you know of anything, or do you know of the debate around that? I think I have muted you. Sorry, Ming, go.
No. Ming, I don't know whether you want to say anything. Hey, Ian and I know each other already, and I just presented on this in a session with Ian at the IAPB Council of Members. In China specifically, Ian, no, there hasn't. There's a lot of, as Ming pointed out, in the various county by county, the situation for the health insurance is different. And in a lot of the counties, there's been different regulations put in place, some useful ones to make sure that the cost, that various aspects of the cost is capped. So it's not just a cap like it is in the Philippines or whatever, but there's different ways that they go about it, which helps the insurance scheme. But what happens is that often those costs are then pushed onto the patient. So as Lexi mentioned, there's an IOL that is fully reimbursable, and Ming mentioned under the under the NCMS, but quite often there'll be a more expensive IOL that is prescribed. The patients have choice generally, but that often it's a more expensive one for some reason is chosen, and then anything above a certain 70% or a certain percentage, depending on the county, falls back to the patient. Similarly with inpatient stays above a certain number, all those kind of things. So there's been some useful regulations for cost control put in place in China. What that often means, though, is that the patient out-of-pocket cost is higher. So in China in general, as you probably know, it's one of only a handful of countries where healthcare coverage of the health insurance is very high, but out-of-pocket costs are also increasing over time, and usually those two don't go together.
Yeah,
whether that
thanks,
answers
Debbie.
your question.
Well, I think it shows sort of the kind of complicated you know, environment really that we're sort of working in, and some of the challenges that will be faced with, you know, the whole eye care sector moving forward, not just in China but in other countries as they sort of begin to roll out health insurance and what those implications are. So no, thank you, Debbie. Right, final question from Sudeep from Operation Eyesight. So in regard to Orbis showing on the fundraising channel, what percentage of the contribution, what is the percentage of contribution that comes from the donation source? And this is sort of to understand its criticality in continuation of the programme and that sort of sustainability. So Lexi, do you want to kind of take that? But actually, I think it's probably relevant for Fred Hollows as well. We can sort of talk about, you know, the percentage of sort of donor funding for projects and how that will be sustainable moving forward. So Lexi, I'll come to you first and then Ming.
Okay, thank you. For that question, actually, is this part donation is a very small portion for county hospital. Because the most of county hospital in China is a public hospital. The most boundaries investment is from government, government investment and medical insurance. There are very few opportunity for them to get the donation from NGO or from other organization. Most of them will have this opportunity is through their higher level or cooperation hospital. For example, if the tertiary hospital have a cooperation with the Federation Disabled Federation organization, they want to donate the money to do the cataract surgery for blind people. They will cooperate with their county hospital in their building network. But for the county hospital itself, it's very few opportunity to get this kind of donation. For the sustainability listed in our project, the county hospital trained in this project, they have built the relationship with the higher level or tertiary hospital. For the future, after the project's ending, they have a long relationship with each other. The network and the referral network has built up. So we believe the activity and like screening, like training will be continuous start in the county hospital.
Brilliant, thank you, Lexi. And Ming, although the question was really sort of for Orbis, do you have anything to add on this around sort of the, you know, particularly like the SiB donation, and how, when the SiB donation finishes, the work that you're doing will still be sustainable?
I think in our project design, we have several sustainability analysis, and also we will review all the activities in the midterm review, and we will decide which can contribute to the hospital financing or the sustainability. And also, I think when we design the screening for the hospital, we only provide a little subsidy for them, which is not cover their.
Oh, Ming, we're not really hearing you actually. The sound's got a bit.
And also we will help them to analyze the data with how many. Can you hear me?
Yes, we lost
Can
you
you
a
hear me
little
now?
bit there. Yeah, we can hear you now. We heard the bit around you saying you sort of the midterm review and you look at kind of your sustainability indicators there, but the bit after
Okay.
that, certainly I lost.
Sorry.
No, that's okay.
I think I can give you an example. In our project design, we have the screening, and but the subsidy of screening we provide to the hospital is quite small, and which not can cover their cost. But after the screen and after we collect the data, we will help them to analyze those data, such as how many screen and how many got treat, how many the difference income or the OPD numbers compare with before screening or after screening. We will let the house management to understand the importance of the screening, and also we will have, for another aspect, we will enhance their quality of services. So I think we have a different perspective to increase the volume of the patient, and also in our project, we also have some hospital management workshop for the hospital's management staff, and we will help them to have some cost control or the increased volume to help them to make their services sustainable.
Yeah, that's brilliant. Thank you, Ming. So it's almost like you're kind of, by strengthening the system, you're actually helping the system becoming self-sustainable. Brilliant. Thank you. Okay, so we're going to stop the question and answer session there. But thank you for all of those that have been asking questions and really engaging. And thank you to our presenters as well, because we don't know what questions are going to come at us. So I think they've done a brilliant job at sort of, fielding and responding to those questions. So I would now like to introduce Sally Crook, the Seeing is Believing Programme Manager for IAPB, for some concluding remarks. So Sally, over to you. Let's just unmute your microphone.
Okay, thank you, Susan. Thank you. And thank you to our three presenters. I think this has been a really interesting webinar this time. And for me, I'll just go back and sort of reiterate a little bit what Debbie said about how, China is a really good example of an aging population and how the need is growing. And as both presenters said, the need is growing often in the rural areas where, people are more remote, they're further away from services. So this need to keep the focus on improving services at the county hospital level and down to the township level clinics is very important. And I think, the whole issue of how is this going to be paid for and by whom is just so important, while maintaining, quality and coverage and efficiency and everything. And I think, we've just really scratched the surface today. And I think my two things that I've taken home from this is about how, one is about the patient perceptions, and that they really have poor information up front, not only about their need for cataract surgery and the clinical side, they have very poor information on the costs and also what their insurance may or may not reimburse, and the variable reimbursements at the different levels of hospitals and the different choice of IOLs that the different hospitals are stocking and all that sort of thing. So patient information is really complicated in these eye care situations, and I think that's something we need to continue to focus on. And then the other variable is the whole issue around the hospital costs. Lexi was mentioning the issue about the length of inpatient stays and the different costs of IOLs and the different hospitals having different volumes of surgery going on, and whether or not the eye department will accept doing low-cost surgery. They all want to move to high-cost fancy stuff the whole time. It's really complicated. And then the other issue that didn't come up in this, but it is there is always this tension between the tertiary and the prefecture and county level hospitals. And I agree with Debbie. I think it's great that the insurance is trying to push people to the most appropriate level of hospital to have what is usually a simple surgery for cataract surgery. But that tension remains, and the tension remains within the profession of where they would like the patients to travel to and things. So I think there are just so many issues that even as everybody tries to be very sort of logical and sensible about things, it really is a very, very complicated issue. And I think the examples from across different provinces in China just show how complicated it is. And I just feel for the poor patients, it must be incredible, and their families, it must be terribly confusing and complicated to try and understand. And like Ming's example of somebody who got some money together to go to the hospital and then found out it wasn't enough, it just shows how people are trying to understand the system, but it really needs to be made very clear and transparent for everybody what these costs will be and what will be met by your insurance coverage, and then what would be needed to be a co-payment or an out-of-pocket payment. So thank you for all three of you for really raising some very complicated issues. But as we know, across Western Pacific and Southeast Asia, lots more insurance is being introduced. So complicated discussions for all countries, I think, wherever you're trying to run an eye care program or to engage with the issues there. But thank you very much for all your presentations today. Thank you.
Thanks, Sally. Oh, excuse me. And for giving a great summary of an hour and a half discussion and some really important take-home messages there, which I think are relevant for all of our SiB projects in the region. So thank you for that. So I would like to end now by thanking all of our presenters, Debbie, Lexi, Ming and Sally, for their comprehensive presentations and responses to all of the questions. And thank you to everyone who's participated today. I really appreciate you all taking the time to be part of our Seeing is Believing learning community. Thanks again, and look forward to seeing you all at future Seeing is Believing webinars. Thanks everyone. Thanks speakers. Bye.
Bye everyone.
Thank you.
Thanks, see you.
Thank you, bye.
Thanks,
Bye.
Bye.